Thanks for having me, guys. I'm really happy to be here. Today I've been asked to talk about schoolyard injuries. It's my understanding that some of you guys are school nurses, but there's also some public health. So I tried to put this together in a way that it hopefully is beneficial for everybody that's in the room, at least part of it. So getting started, as far as the talk itself, I just wanted to kind of define what a sprain is versus what a strain is and what a fracture is. Talk about pediatric fractures and kind of how they are unique to the pediatric population as opposed to adults. Common upper and lower extremities that you are likely to see either in a schoolyard setting or primary care setting. And then basic splinting. If I don't get time to show the little video that's embedded in there, I think you guys have handouts of the slides. They're YouTube videos that were actually created by my partners. So if I don't get to them today, I encourage you to go home and look at them. We have videos both on basic splinting as well as casting, just depending on what material you have available to you. So soft tissue injury, most acute injuries across the population are soft tissue injuries, sprains or strains or contusions. And while that is also true in pediatrics, we'll talk about how you have to have a bit of a higher suspicion for fracture. And again, this includes sprains, strains, or contusions. So a sprain is an injury to a ligament. Now a ligament is soft tissue that connects bone to bone, typically from excessive stretching. So the most common example usually of this is if you sprain your ankle or you roll your ankle, you have ligaments that connect bones in the ankle, and that's typically what is injured. A strain is an injury to a muscle or a muscle tendon unit. Usually from a forceful contraction against resistance. Probably a very common example of this is a hamstring strain. A sprinter tries to take off and the muscle pulls. So either the muscle unit or the muscle tendon unit pulls. And again, it's a muscle, a tendon attaches a muscle to a bone, a ligament attaches bone to bone. And then a contusion is essentially a fancy word for a bruise. So I have 3 kids at home, twin 2-year-olds, and we just welcomed boy number 3. May 4th, so you're going to be inundated with pictures of my kids. So children are not small adults and should not be treated as such. This is an incredibly common theme that was spouted off multiple times during my general pediatric residency, and it certainly is just as pertinent in pediatric orthopedics. And again, I'll a little bit later in the talk, I'll talk about why pediatric injuries are unique. And why, while oftentimes in an adult you will presume maybe a sprain or a strain, to not presume a fracture in a pediatric patient may be a mistake. And I also use this picture here. Again, this is my one son, Landon. And you can see he's got his little push fake lawnmower out there. I think some of you guys are in public health. There are a couple of things as pediatric orthopedics we harp on. And trampolines are one, I'll get to that, but one that that I have essentially no excuses for or no room for tolerance is when it comes to lawnmowers and lawnmower injuries. Essentially, if you have a child who's 10 years of age or less, if a lawnmower is being operated outside, I don't care if it's a lawnmower, a push mower, whatever, that child should be inside, period. In the month of May, we had 3 children who sustained lawnmower injuries. Most of the time they involve the toes, the feet, or some body part therein. And unfortunately with the lawnmower injury, overwhelming majority of the time, the treatment involves the word amputation in some way. So, I can't, as far as an advocate for kids, as far as public health, that's something that, if you get a chance to address, I think it should be. Pediatric fracture and mechanism are often unique. This is Landon's twin brother, James. He's probably about 6 months old at that point. But, again, the manner in which kids get injured can often seem relatively innocuous. And as I get into pediatric bone, you can see why their fracture pattern is unique. So pediatric bone, children's bones, the obvious difference between that and adults is that they have open growth plates, or what are called physes. And fractures in pediatric immature bone are incredibly common. As not just to do with the presence of growth plates, but the way the bone is made up in and of itself. They have a very thick, what's called periosteum, which is kind of the outer cortex of the bone. and that allows them to absorb an incredible amount of energy before they break. In other words, which can cause what's called a plastic deformation. So if you've ever gotten a toy or bought in something that comes in a kind of heavy plastic material, if you've ever tried to open it, trying to tear it is incredibly hard, but it does tend to bend, not too difficult. Unfortunately, not very easy to open. And again, so because of these two things, unique fracture patterns are a result. I'm sorry for this very wordy PowerPoint, or this very wordy point here. I'll just read it and then explain it. The tensile strength of pediatric bone is less than that of the ligaments. So the same injury mechanism causing ligament injury in adults, a sprain or a strain, is more likely to cause a bone injury in children. So in other words, if a child rolls her ankle, quote unquote, or sprains her ankle, quote unquote, the weak spot in the bone, so to speak, is the growth plate or the physis, as opposed to the ligament. So if you have a 6-year-old who rolls her ankle and that thing swells like you would see in an adult ankle sprain, I would be willing to bet it's a fracture of the growth plate, or I would presume it to be, as opposed to thinking it's an ankle sprain. Okay. So just looking at pediatric bone in general, again, I mentioned that the growth plate is also termed the physis. Distal to the end of the bone there, the region is called the epiphysis or epiphysis. The shaft of the bone is called the diaphysis. And then the region between the shaft of the bone, or the diaphysis, and the physis, this little region right here is called the metaphysis or metaphysis. So again, I'm sorry that this didn't come out quite as clear as I was hoping it would, but I at least changed the words down here so it's hopefully easier to see. So a couple unique fracture patterns. One you may have very commonly heard of as a buccal fracture, or sometimes called a torus fracture. Just to be a dork for a moment, the torus word is actually from the Greek. It refers to the shape of a column, and that's also the kind of the same shape that the bone takes when it deforms. Basically, there's a compression and the bone buckles out, and so as opposed to getting a complete fracture across, there's just a plastic buckling or deformity fracture. Green stick fracture. I think the very simple way to think about this is just like if you ever were a kid. If you've taken an old wooden stick and you snap it, it snaps really easy. Unfortunately, kind of like an old lady's hip. If you ever take a kind of green, healthy young stick and you try and break it, as opposed to it just snapping like a twig, usually what happens is it bends, and then the part of the stick on the other side that you're pushing on kind of snaps a little bit, and then the side that you're pushing on stays intact. And that's exactly what happens in a green stick fracture. So basically, someone's kind of pushing on this side, they push, and then the other side pops and gives, but the other side stays intact. And then the last portion here just involves growth plate fractures. You may hear the term Salter-Harris fractures. That's the classification system for different growth plate fractures, and that refers to where the fracture is relative to the growth plate and whether it's above or below it. In other words, in the epiphysis or the metaphysis or both. And I think the whole classification system is a little bit, we won't belabor that, but those are some of the unique fracture patterns that you see in peds as opposed to adults. So upper extremity injuries. I'm going to go over clavicle fractures, briefly go over elbow injury, forearm injury, as well as some finger injuries. So as far as evaluating upper extremity for injury, and I'm kind of referring to clavicle or shoulder, but you'll see an incredibly common theme for the rest of the upper and lower extremity. The first thing you do when you come across a child who seems to have an upper extremity injury is assess the situation. Ensure that the patient is safe, and not maybe just the patient, but yourself. If this patient happened to endure an injury in an unsafe situation, you don't want to have the child be at any more risk, or you as the caretaker. Attempting to determine the mechanism of injury if it's unwitnessed can often be incredibly helpful in deciding what the injury is. I hopefully get to it a little bit later, but there's a very common injury called a nursemaid's elbow, which the child can kind of look and act like they have a fracture, but they don't need a cast, they just need a very brief manipulation. But if you don't have the mechanism of how it happened, you can't make that determination, or in other words, you would have to presume it's a fracture until proven otherwise. It can be sometimes difficult getting the mechanism if your witnesses are 5 years old, but if you can find it out, it's often very helpful. Look first. Is there an obvious deformity? Is the bone sticking out of the skin? Or if the bone isn't sticking out of the skin, is the skin disrupted? Besides assessing the severity of the injury by looking first and not just going up and pushing on it, you will hopefully establish a little bit of rapport with your patient. Most 6-year-olds will not like it if you just go push right on where it hurts. And then finally, if there is an obvious deformity, again, is the skin open? Is the bone disrupted and actually poking through the skin? And is the blood supply intact? In other words, checking pulses distal to where the injury site is. So again, just brief review of shoulder anatomy. And I do a couple of these just because I think in assessing these injuries, sometimes what can be incredibly useful or helpful for everyone is just being able to communicate to whoever you call, what the injury is or where you think it is. And so I'll go over a couple of nautical anatomy terms just to hopefully help if you ever are in the situation where you have to call and speak with someone in our office or a doctor in the ER, and trying to kind of help identify where the fracture is or a relative location. So this is your clavicle or collarbone. Kind of hard to appreciate it in this view, but it's an S-shaped bone. So this portion right here is actually coming out at you, and then as you go distal or lateral, it's going back behind and then straightening back out again. So if you were looking at it from the top, it forms an S. This is the sternum here, and out here is the acromion right here. So, anatomy, it's wonderful. It's relatively intuitive, So here's the clavicle, there is the acromion. So that is the acromioclavicular or AC joint, which you probably have heard of, often sprained. This is the sternum, and this is the clavicle, so this is the sternoclavicular joint. Oh, and sorry, and I mentioned some anatomy terms. Now, most often the kind of common language used for clavicle fractures, or the preferred terms, would be a midshaft, distal, or proximal fracture. But if you told me it was lateral or medial, I would know exactly what you're talking about. Medial being closer to the midline, lateral being farther away. So clavicle fracture is one of the most common fractures in pediatric orthopedics, about 5 to 15% of all pediatric fractures, and that's a very large number. Typically it involves a fall directly onto the outside of the shoulder, compressive force. As most of you, I assume, do not have an x-ray machine on site. So besides the child not moving their arm, besides the child not having a gross deformity of the clavicle, by gently pushing or palpating over the injury site, if you feel kind of a popping or a little crackling sensation, that is something termed crepitus and can be an indication of a fracture. And this is most commonly treated with just a simple shoulder sling or swath. Now, I tried to keep treatment somewhat broad because I didn't really know what everyone in the room would have available to them as far as resources in treating these injuries. So, on the left is incredibly unclear and fuzzy picture of a shoulder sling, and this really can be as simple as a very long oversized shirt or bed sheet that you essentially tie around the neck and then support the majority of the forearm as best you can. On this side right here is basically what we use in our office, and what this is a basic shoulder immobilizer around the arm, and then over here is just a swath which just wraps around the body and helps hold the arm against the body, tends to provide a little bit more comfort. It also tries to take a little bit of strain off of the neck because most kids hate these things where it's kind of pulling on their neck when they're in them. Now, is anybody here ICU, NICU, anybody? Yeah, awesome. So it's not too uncommon for, a young baby is born, it's a rough birth, the baby comes out, they're not using their arm, they get an x-ray, and lo and behold, there is a clavicle fracture, and we will sometimes get somewhat panicked phone calls in the office from the newborn nursery or saying, Doc, Doc, the baby's got a clavicle fracture. It's I don't know if it needs surgery. I think they can keep their arm. I'm not sure. Can you come see them right away? And and we try as kindly as say, no, it's fine. Just take a little pin the little sleeve to their arm, they'll be fine. The old saying for clavicle fractures in pediatrics is that as long as the two ends of the fracture are in the same room, they will heal back together. This is a This is so you can see, this was obviously a clear disruption of the clavicle right here, with kind of a splitting or wide deformity of the proximal portion of the fracture. This is just, I think, maybe a week or two into life, and I saw this young man a couple of months later, and this is the same kid with obviously complete resolution and healing of the fracture. The healing and remodeling potential for this is incredible. So unless it literally is poking out of the skin, we almost do nothing for it. Elbows. As far as just briefly, so this is looking at the front of the elbow like this. This is the humerus bone right here. This is the outside or lateral portion. This is the medial portion. Now these are what are called the condyles of the humerus, and there's an incredibly common elbow injury you may have heard of called a supracondylar fracture. So just in case you had ever heard of that or were wondering, the reason it's called a supracondylar fracture is, again, here's the humerus, down here are the condyles. The fracture is often right about through here or in the supra or above the condyles location. And this is just a side view or lateral view looking at the elbow. Again, this is the humerus coming down. This is a bone called the capitellum. This is actually your ulna bone or your pinky side bone, and that's where the humerus sits in and where your elbow moves. That's where the hinge joint is. So elbow fractures. Far and away the most common mechanisms I see are this guy right here, trampolines, and then not so distant second are monkey bars, but this takes the cake. This keeps the lights on in our office. It's true. It's really true. And I don't care if it has a net on it or not, but that's different. Anyway, so again, if you have a child who seems to have an elbow injury, the principles are incredibly similar to any upper extremity injury. Assess the situation, look for deformity, and check the blood supply. Now, I threw this up here as far as checking to make sure their motor nerves are working, or making sure the nerves that can potentially be injured are working. If you have a young child who just injured their arm, if they don't want to move their hand, that may not be because nerves are not working. That may just be because they are hurt and they don't want to move their hand. And so that's okay. But if you have a child who has an elbow injury, they seem to be calm, you've potentially splinted them, they seem like they can kind of follow instructions, then a very simple way to make sure that the major motor nerves are working is if they can lift their thumb up, if they can make a circle, and in particular they can bend their thumb like this. So lift your thumb up, make a circle, and then spread your fingers apart. If you can do those three things, then the major motor nerves we're looking for are working. And if anyone was interested, that's the radial nerve, the median nerve, and the ulnar nerve. So swelling or asymmetry after a fall, okay, in a pediatric elbow, in my opinion, that is a fracture until proven otherwise. I mentioned before something called a nursemaid's elbow. If I went back to the previous anatomy slide, where the radius or thumb side bone comes in contact with the elbow joint or trochlea, usually in a 2-year-old or 3-year-old, if there's a sudden pull or jerk on an arm, the ligament that helps keep that in place can get popped out. Now, this can very easily be put back by simply turning the arm up and bending the elbow. Unfortunately, I have seen multiple times in an ER setting where a young child comes in and they're not moving their arm, and for whatever reason they presume it to be a nursemaid's elbow, and these children have attempted manipulations of elbow fractures. Again, unless you have a clear mechanism, no swelling, it should be presumed a fracture until proven otherwise, especially if there is obvious swelling and certainly if there's deformity. On-site treatment for an presumed elbow injury or fracture, again, I'm not sure what you may or may not have available to you, but assuming there's not gross deformity, a simple shoulder sling or swath, just like I showed for the clavicle fracture, as long as there's sufficient support of the forearm, will often be sufficient. Otherwise, a long arm posterior splint is often the optimal treatment. And again, the splint material, whether you have old-fashioned material or the kind of the newer one-step splinting material, where you basically just get it sort of wet and then plop it on there. It just goes along from about the lower part of your shoulder all the way down the backside of the forearm there. And if you do the one-step splinting material, you want to have some material underneath it. You don't want to just put the splinting material directly onto the arm. So whether you have stockinette material, something called web roll, or just basic ACE wrap. The forearm wrist, again, I apologize for the picture. The only thing I really wanted to point out here was, again, with the forearm, the thumb side is the radius bone, or the big bone out here, and the pinky side is your ulna bone. Now, I mentioned before, medial is closer to the midline or chest. Lateral is going away from the midline. So that's all well and good, but if I'm looking at my arm, my thumb, if I have it like this, well, my thumb is lateral. If I turn my arm like this, now all of a sudden it's medial. So what's right? What you can remember is this right here, the way I am standing. This is what's called the anatomic position. Okay, so essentially the thumb or the radius is considered lateral, and the pinky or ulna is considered medial. However, in a situation where you're trying to take care of a screaming child and you're like, oh, what did he say? What did he say? If you tell me that it's on the thumb side or radial side, I know what you're talking about. It's as far as communicating to whoever you speak to, it's making sure you can do so, confidently and correctly. Forearm and wrist, again, very same principles for the other upper extremity injuries. Swelling and asymmetry, again, a fracture until proven otherwise. And this seems like a small thing, but really, I've seen plenty of kids, and this is, parents do this all the time, and very understandable. 3-year-olds tend to fall a lot, and oftentimes a fall can, just seems like another fall. It's innocuous, and they cried, they hurt their arm. I thought it was no big deal, and then 4 days later, they still didn't like it when I pushed on their arm. and that again, if you have one of those situations where a kid falls at recess, and they kind of seem to shake it off, but 3 days later you happen to see them and they still have swelling in that area, or you feel like they have swelling at the wrist, or they still seem to hurt when you push on it. 3 days later, that's not a sprain in a 4-year-old or a 6-year-old. That's a fracture. And even if it's a small buccal fracture that can be treated with a wristlet, should still be evaluated. But another thing to kind of keep in mind, especially in an unwitnessed injury, my rule of thumb, if I see a child who seems to not be moving their arm or upper extremity, wherever the parents seem to think they're hurting, to check the joint or portion of the arm above and below the joint is important. I recently had a young person who came in for what was thought to be an elbow injury or a proximal forearm injury. But he clearly wasn't moving his arm, and so I got X-rays of his upper extremity, of his proximal humerus as well as his hand, and he had a proximal humerus fracture. So sometimes, oftentimes a 5-year-old or a 4-year-old is not going to be very good at communicating exactly where they hurt or telling you exactly where the pain is. Again, this is a video I have that it's not going to play in the PowerPoint presentation. If I don't have time at the end, I encourage you to look at them. Finger fractures, generally speaking, if there's no gross deformity, whether you have an alumifoam splint like that's pictured right here, simple buddy taping, a popsicle stick with some overwrap, most of the time that's relatively sufficient for a finger fracture that's non-displaced. Generally speaking, the kind of happy position or safe position is if you have the fingers bent at where the knuckles are, or what's called the MCP joint, and have the other portions of the fingers or phalange joints, what's called the PIP and DIP, in a straight position. You'll often see kids come out of our clinic with what we call a mitten cast, or a duckbill cast, where the fingers are kind of in this position. Those are often for fractures of the index finger or middle finger, kind of proximal, kind of hard to cast those any other way. The only, there's a similar concept with toe fractures. I will give you one exception where I would say that more acute management or evaluation is potentially warranted. If you have a young person who clearly injures their finger or their toes, especially their big toe, and there's swelling and what seems to be a break or disruption of the nail bed, at the base of the nail bed where there's clearly bleeding, okay? Even if it's not a fracture that needs surgery, if there is a fracture with a broken nail bed with bleeding, we consider that to be an open fracture, okay, because of the exposure, and those kids are often treated with antibiotics in addition to whatever splinting or casting or bracing they may get. That's my kind of one exception there. So lower extremity, I just kind of focused on foot and ankle because it's far and away the most common. Again, I really am apologizing for these crappy pictures over here, but I wanted to try and just compare, as far as anatomy here goes, in the leg, the big bone or inside or medial bone is the tibia. The smaller or outside bone is the fibula. And they both come down to help form the top of the ankle joint. The other bone that helps form the ankle joint is something called the talus. And if as far as your foot or ankle itself, the two sticky outy portions on the inside and outside of the ankle are your tibia bone right here and your fibula right here. And this is just a comparison view on an X-ray of the looking at the front of the ankle. So again, here's your tibia. That's your growth plate. That's your epiphysis or epiphysis. This is again the medial mal or inside portion of the tibia. Here's your fibula, growth plate, outside portion. These are just looking at all the various ligaments that I mentioned before that you can sprain. If you have a relatively older or more skeletally mature kid, 15, 16-year-old, then yeah, most of the time that can be a sprain. Foot, ankle, inversion injury or rolling the foot in is the most common mechanism. In the younger patient, again, child is not a small adult. If you have a 2-year-old who seems to have a relatively innocuous fall, and they are refusing to bear weight on the leg, even if if you send them for X-rays and the X-rays are interpreted as negative, if they show up in my office because they're still limping 2 days or 3 days later, we treat that as a fracture. Okay, it's actually a very common fracture. It's so common it's called a toddler fracture. And the toddler fracture is typically a spiral fracture of the tibial shaft that can often not show up on an X-ray. Sometimes if you do what's called an oblique view of the X-ray, you can sometimes see it. But oftentimes you won't see anything until you see them a few weeks later and take them out of the cast, and lo and behold, there's a whole bunch of new bone or callus formation on their leg. So again, a toddler who is limping, that's typically not a sprained ankle, which unfortunately I just have seen a few times now. And again, this just goes back to the idea of a young person with a swollen ankle, certainly 10 years of age or below, I would presume it to be a fracture until proven otherwise. It's not that they can't sprain their ankle, but again, this is just another link for splinting of the ankle. Plaster or splinting material. Again, orthoglass is that kind of like relatively newer kind of one-step material, as opposed to the old-fashioned plaster where you kind of layer it out and get it wet and then put it on. Air splints or crutches. Again, depending on what you have available at your location, it's probably most important to have something that is comfortable and can help stabilize the ankle joint, typically going up the medial and lateral sides. Again, whether that's an air splint or splinting material. So just in summary, the presence of physes or growth plates and the makeup of pediatric bones make pediatric patients susceptible to unique fracture patterns. In the acute injury setting, you want to make sure you check the skin and the blood supply. And then swelling and deformity in extremity for a pediatric patient is a fracture until proven otherwise. And again, I told you it'd be in a day. So these are my little guys. So even if they look like that, that's James. Yeah, my little dudes. This is my new guy. This is Theodore Edward. We call him Teddy. And the little guy's homies. I put this up here because they were about they turned 2 in February, and so I think they were less than a year old here, and this was last time we were at the, so it's amazing to me watch them grow quick. That's the little guy there. So, and that's it. Thanks, guys.